In this following video, I'm going to discuss with you all that you possibly need to know in the surgical management of patients with posterior polar cataracts. Let's start with understanding what would be the ideal technique of managing polar cataracts. Now, we do know this much, that a posterior polar cataract is a patient with an abnormal opacity in the posterior pole with an abnormal attachment to the posterior capsule. Meticulous care and attention to detail need to be taken while creating the incisions and an oval rhexis. We now start watching the surgery from the point of the hydrodelineation. We bury into the substance of the nucleus and inject fluid to thereby delineate the endonucleus that appears like a golden ring. With low flow settings, which is a power just adequate to impale and emulsify the nucleus, a vacuum of about 200 millimeters of mercury, and a flow rate of about 20 to 24 cc per minute, we start with the phacoemulsification. Because there is significant density to this nucleus, I plan to perform a direct vertical chop with a limited lateral separation in situ. As you can see, I impale into the nucleus, and once I've held it firmly with the phaco probe, with the second instrument, I create a vertical chop. Without rotating the nucleus, I impale into the left heminucleus and then into the right heminucleus and break it down into smaller fragments. Now, once you bring one of the fragments out of the eye, you have enough room, and I believe at this point it's a lot safer to rotate the nucleus. After emulsifying the small fragments, each of the residual heminuclei are impaled, brought out of the capsular bag into the phaco-safe zone of the pupil and emulsified. Following the completion of the nucleus emulsification, I take my time to visualize the posterior capsule. I look for any rent that might have been created during the nucleus management. As you can see here, there seems to be no rent in the PC as of now. Having done this, I now perform a viscofluid exchange, which is a very important step which I need to perform before bringing the phaco probe out of the eye. Moving to the epinucleus management. The best way to remove the epinucleus is to do a hydroprolapse of the epinucleus, as you can see here. I do not believe that it increases any extra pressure into the capsular bag, and having prolapsed it into the center, as you can see here, facilitates its easy removal. I remove the subincisional epinucleus by drawing it out with a Sinskey hook from within the capsular bag. At the end of the epinucleus removal, once more I perform a viscofluid exchange after looking and checking for a posterior capsular rupture. Next, I move to performing the bimanual irrigation aspiration for removal of the residual cortex. As you can see, one half of the cortex is removed at a time, and prior to swapping the hands around, notice how I always perform a viscofluid exchange, both prior to swapping the hands and finally even at the end of the cortex removal. Now, this is followed by the implantation of the single-piece monofocal IOL within the capsular bag. The excess viscoelastic is then washed out from the anterior chamber. Care and caution needs to be taken to not perform excessive rock and roll movements of the IOL, because that itself could disrupt the posterior capsule. At the end of the visco wash, the wounds are hydrated whilst maintaining the irrigation still in the eye. Finally, the irrigation cannula is removed, and that paracentesis incision that has the irrigation cannula is finally hydrated, thereby bringing us to the end of this surgery. Let's now move to discussing the second case, a patient with a polar cataract who had a PCR with a vitreous disturbance, and let's see how that was managed. In this case, while removing the last part of the epinucleus with the phaco probe, the surgeon suddenly noticed the presence of a PCR. The last bit of epinucleus was aspirated. A visco fluid was then performed. Now, despite performing a visco fluid exchange, you can notice that the rent has extended in its size, signifying the presence of vitreous. In order to delineate the vitreous, triamcinolone acetonide was injected into the anterior chamber. We then proceeded to performing a limited anterior vitrectomy. Note how the vitreous is first cut at the site of the incision, after which the vitrectomy cutter, now introduced into the eye, cuts the vitreous from within the wound and then from within the anterior chamber. The anterior chamber is maintained by the irrigation which is introduced with my non-dominant right hand. Note how the vitrectomy cutter was always facing upwards, and having cut the vitreous from the anterior chamber, I then moved to the area of the pupil and then to the area of the posterior capsular rupture. Note how I never go behind the area of the posterior capsular rupture. The end point of the vitrectomy in this case is the absence of any stained vitreous in the anterior chamber and the PCR going back to its normal size. After which, I now move to implanting the 3-piece IOL in the ciliary sulcus. Having successfully done so, I now remove the excess viscoelastic from the anterior chamber, and this brings me to the end of the surgery. Let's now move to the next case wherein there was an intraoperative PCR, but how I managed to complete the case without disturbing any vitreous. I start with the nucleus management of this very soft endonucleus. Having impaled the endonucleus with a probe, I bring it out of the eye, but whilst bringing it out of the eye, notice a large PCR behind it. At this point, there seems to be no vitreous disturbance, so I choose to complete the nucleus management in this case. I draw the endonucleus up anteriorly and emulsify it. I then proceed to aspirating the epinucleus. Following the completion of the epinucleus removal, I perform a viscofluid exchange. I then proceed to perform a bimanual irrigation aspiration for removal of the cortex. Prior to swapping the hands during bimanual irrigation aspiration, I perform a viscofluid exchange. At the end of the bimanual irrigation aspiration, here's what I notice. The tear in the posterior capsule is an incomplete tear. And in order to make this a stable opening, I introduce an intraocular forceps and notice how I convert this partial tear into a stable circular inferior opening. This stable opening is now no longer going to enlarge. Having achieved this, I now proceed to implant a 3-piece IOL in the ciliary sulcus. Once the 3-piece IOL is rotated in the ciliary sulcus, I now proceed to perform a posterior optic capture. And so you would have learnt in this case that despite having a PCR, I managed to avert any vitreous disturbance. I managed to place a 3-piece IOL in the ciliary sulcus and achieve an optimal orientation of the optic within the capsular bag by performing a posterior optic capture. I'd like to now take you to the third case, a case where the most important take-home message is that a tear in a posterior capsule in a polar cataract can occur at any time in the surgery. Now in this case, up to the point of the IOL insertion, the surgery was uneventful. But note how some amount of excessive rock and roll movement of the IOL for removing of the excessive visc has resulted, as you can see here, in a tear in the posterior capsule. Now, since this seems to be a small tiny tear and the IOL seems stable in the capsular bag, I chose to leave things exactly as they are, that is a stable IOL in a bag with a limited PCR, and hydrate the wounds. And whilst hydrating the wounds, once more note how I maintain the irrigation in the eye to prevent any decompression of the anterior chamber, thereby enabling me achieve an optimal end result. Let's now move to watching the last case of our series, a patient who now presented to us with a soft polar cataract and, as you can see here, a pre-existing posterior capsular rupture. I start with a very careful hydrodelineation to demarcate the endonucleus. Having done so with low flow settings, I proceed with the nucleus management, wherein I impale the endonucleus, bring it out of the capsular bag and virtually aspirate it. I then attempt to remove the epinucleus with the phaco probe itself. As I proceed to remove the epinucleus with the phaco probe, you will start to notice the underlying PCR. Unable to remove any more of the epinucleus, I perform a viscofluid exchange. With the help of a Sinskey hook, I then draw out the subincisional epinucleus towards the center and aspirate it. Having removed as much of the epinucleus as I can, I perform a viscofluid exchange, remove the phaco probe from the eye, and then proceed to performing a bimanual irrigation aspiration to removing the rest of the cortex. Having used a dispersive viscoelastic to perform a viscofluid exchange, I'm able to prevent any vitreous herniation in this case. With care and caution, I remove the rest of the cortex. Once the right half of the cortex is removed, I perform a viscofluid exchange once more, swap my hands around, now use the aspiration from the right side to remove the residual cortex. Following the complete cortical cleanup, I enlarge the incision to about 3.4 millimeters, and now I implant a 3-piece IOL in the ciliary sulcus. Having completed the implantation of the IOL in the ciliary sulcus, I then proceed to performing a posterior optic capture. The excess viscoelastic is then removed from the anterior chamber, after which all the wounds are hydrated, thereby bringing us to the end of this surgery. This brings us to the end of this video tutorial. I hope you found it useful. Thank you.